All right, guys, third time's the charm. I tried to record this morning, but I paused it to teach you, and then when I came back, it didn't have the recording. I don't know what happened, so going again. This is geriatric radiography. I'm supposed to deliver this Monday afternoon, and you're supposed to have access to this recording by Wednesday, so I gotta get it done tonight. Okay, so what are we talking about with geriatric radiography? Well, we got to talk about the process of aging, and it's not, nobody ages in a vacuum. They age with their genetic history, whatever genes their parents and their grandparents and grandparents gave to them. They age within their culture, they age within their socioeconomic standing. And so all of those things play a factor in how the aging process goes for all of us. Unfortunately, in this lecture, we have to take some time to talk about elder abuse and the signs of elder abuse in this modern era. It's getting more and more prevalent, and so they want you as a healthcare practitioner and professional to recognize the signs of elder abuse so that you can be a safeguard against it. We'll talk about the physiological effects of aging. We'll touch on some of the major organ systems and some of the issues that happen related to X-ray. I think I talk about skeletal musculosystem, the respiratory system, and the cardiovascular system. In particular, the book goes into a couple more, but I trimmed some of that content for time. Exam performance is changed to accommodate the elderly patient. Yeah, that's basically the whole point of this. Is the most important objective of this entire lecture, is to tell you that the elderly people have certain issues, some of them common, some of them rare. Not every elderly person is the same, but these are some of the more common things with elderly people. And this is some of the accommodation that we'll have to do when we're doing an X-ray exam on an elderly person. We have to accommodate for some of these things that we bring up and talk about. So through understanding all of that, you will come to understand best practices for geriatric radiography. All right, so what is a geriatric, first of all? Pertaining to old people. The geriatric population is 65 years of age or older. Now, is that a cultural norm? Is that just an arbitrary number that we picked to say that's the retirement age way back when? I'm not sure. I'm not sure where we get that number from. Aging seems to me to be a continuous process. It doesn't ever stop. And depending upon the level of abuse that you subject your body to when it's younger, determines how fast you age in some respects. So your chronological age might be 50, but your pathological age might be much higher because you have eaten bacon double cheeseburgers and smoked 2 packs of cigarettes and washed it all down at night with about a third of a bottle of whiskey, night in, night out. Not that I'm saying any of you have done that or I have done that, but I'm saying if you do that kind of stuff, you don't get enough exercise, you don't eat right, and you smoke and drink to excess, well then yeah, the aging process is going to be harder for you than other folks because you've already put some of the mileage on before it's time, so to speak. Okay. And so we do encounter some, look at how happy these people are to be exercising. You got to be kidding me. That's staged. Sorry, side note. We're going to talk about some of the problems with aging, and some of the problems is just plain old, how much did you plan ahead? Do you have financial independence or financial dependence? And that might be the biggest factor of all the factors that we're going to discuss on the next slide. Okay. Well, not the next slide. It's coming up though. All right. So when we talk about gerontology and geriatrics, um, a lot of times the focus is on illness prevention or management. Like if it's a chronic condition, the best we can do instead of curing it is management of the condition. Talking about maintenance of health and preserving the health that we have and maintaining a quality of life that is desirable. And a lot of times that's the focus of healthcare for the geriatric. They know that they're not getting younger, but they just want to be able to enjoy life the way they've been enjoying it. They might have to make some adjustments. They might have to make some changes if they want to maintain a certain quality of life. Um, but that's the main focus of the conversation typically. Versus with younger folks, it's more acute injury, and then we don't really visit the doctor unless we have an acute injury. So studies have shown. So what does the green table show? Because the bullet points in the green table talk about two different things. The bullet point says that factors affect the quality of the aging experience, including gender, race, ethnicity, which is different than race, and social class. So let me take them one by one. Gender, whether you're male or female, um, male patients have greater risk of heart disease. Um, Female patients have greater risk of osteoporosis. And so gender has an impact as to what um, what possible conditions are more likely to manifest. That's not saying that women can't get heart attacks. They most certainly can, but it's less common than a man getting a heart attack. Race is different from ethnicity. Race deals with your genetic makeup and genetic predisposition to certain types of ailments. For example, sickle cell anemia abnormally affects African Americans. Okay, there's just higher prevalence of sickle cell anemia in African American populations than there are other races. Okay, dementia is more common in Caucasians than other races, and so as you have a genetic makeup, that genetic makeup partially determines what's more likely to happen. There's a certain genetic quality to some of these conditions that show up later in life. Now, ethnicity deals with culture, okay? So, did your grandma raise you? Did your mama raise you? Is your grandma living in the same house as you? Is your grandma living in the same town or down the street? Is she 3 states away and your mom and dad don't want to have anything to do with her? That makes an impact on grandma's journey into old age. Okay. Typically, the more socially knit grandma is to her family, um, the more likely she's going to have a positive aging experience. And I don't mean to be sexist; it could be grandpa too. But you see this culturally. The Japanese, I don't, I as far as I know, they don't have nursing homes in Japan. And that's because the elderly people move in with their children. And it's just a cultural norm that as you get old and weak and infirm and you're no longer able to care for yourself, that's what your children are for, is to take care of you. And so we have nursing homes in this country, and that would be completely alien to a Japanese person. So that's what we mean by ethnicity. Different cultures have different reverence and respect for the elderly and different strategies for what happens when grandma or grandpa can't take care of themselves. Okay? Social class, I mentioned this is socioeconomic class. Probably the most important factor of all the factors is Does the patient have health insurance, and do they have access to modern medical care? So part of that is what country are they in, and part of that is how much do they have saved for retirement? Are they financially sound, or are they financially dependent? Um, and that determines, in some respects, the quality of care, unfortunately, that you receive. All right, so we know that the economic status of the elderly varies. We also know that just because you are financially sound doesn't mean you have avoided all the pitfalls of aging, because we see that elder abuse is more prevalent with elderly people that are financially sound, because that's motivation. The people who are preying on them are probably absconding some of their hard-earned wealth, and conning them or bullying them out of it. So, single and minority elders are more likely to have income at or below the poverty level. And that's a real crisis, because healthcare becomes less of a priority when you are poor. When you're poor, you want to eat, you want to get a good night's sleep, you want to be able to do your laundry, and you want to keep your job. And those are your life goals. Okay? And so long-term health care, and how long am I going to live, and what's a healthy diet to adopt, and do I have enough exercise? All of those are actually luxury considerations after you meet your basic needs. And if you're in a poverty status, your basic needs might not be met, and you don't even consider things like a healthy diet, and exercise, um, because you're so consumed with just acquiring the basic necessities on a regular basis. Okay. Um, Poverty. I've been in poverty when I left my parents' house and struck out on my own. I understand poverty. I was only there for a short period of time, but I understand it, and I understand that it's not a good place to be as far as having a good life and a good healthy outlook. Poverty severely limits your options, and so um, people going through uh, an aging experience and becoming elderly while in poverty, um, it's it's kind of, two hurdles have been raised against them rather than just one. And so it's very tricky. It's hard enough getting old, but getting old while poor seems especially rigorous. Elder abuse. Hope you guys get a giggle out of Mr. Pacino and his now ex-wife. Um, but elder abuse can take several forms, and I think the form this young lady took part in was maybe not illegal taking, but it was definitely exploitation. Um, and as soon as the baby was born, she filed for divorce. So I don't think she really liked Al at all as much as she liked the idea of getting half of his money. Um, all right, so physical, sexual neglect, and exploitation. Definitely the bottom two here, the neglect and the exploitation. That's what we see a lot more on a day-to-day basis. Um, and it's unfortunate. I think exploitation is the worst crime, rather than neglect, but neglect is a close second. Um, Physical and sexual, we get some physical abuse. Thankfully, sexual abuse of elders, at least in my experience, was extremely rare, and we need to keep it that way. Um, but we need to have an awareness that all these of abuse are possible. And so as healthcare providers, we need to keep our eyes open. If only Al Pacino had talked to me, I would have told him it was a trap. But he didn't. So I hope he had a good time while it lasted. Um, Forms of elder abuse, emotional abuse, that's verbal or nonverbal. It's basically bullying, but it could also be passive aggressive type strategies to um, constrain behavior, to get your way with your elderly um, person that's in your life. If you're in the role of a caretaker role, either a son or a daughter or a distant relative or just a concerned neighbor or something like that. If you're being manipulative with them, then you're engaging in emotional abuse. Um, Abandonment is someone who signs up for the responsibility of being a caregiver or being a reliable, responsible person that can help um, with the elderly person's healthcare journey, um, and them coping with perhaps fixed income and new lifestyles and things of that nature. And then they abandon that responsibility. That's a real disservice to the person who is relying on you. And then sometimes it has a huge impact on um, the aging process and the health and well-being of the person who is relying on you. So just be mindful of that. We are only graced with the presence of the people in our lives for a very short time, and then they're gone. And so always cherish that. And if someone is asking you for help, um, cherish that opportunity too, that you get to make their journey just a little bit easier because they think that you can relieve some of their burdens. That's a wonderful blessing that you can share with them. Okay? Self-neglect, that comes from folks are set in their ways, and maybe they get a little lazy about some of their habits, hygiene habits in particular. Not only are hygiene habits essential for polite society, containing body smells and funk and all that kind of stuff, but also hygiene habits are often rooted in um, boosting the natural immune system. The reason you brush your teeth is not for fresh breath. The reason you brush your teeth is to keep down gingivitis, because if gingivitis festers and becomes chronic, it can actually, the next place that bacteria likes to go is the heart valves. And so you can actually shorten your lifespan by having poorly cared for teeth. Okay? And so self-neglect is part of that process. You really, there's a reason we said wash your face and put on deodorant and brush your teeth every day and take a bath with regular frequency. It's not just because you smell, it's because those actually promote good health by limiting your exposure to harmful microorganisms because you're constantly cleaning yourself. And so if you let those habits slide, well, then expect to get sick more often. Okay. So signs of elder abuse. Obviously, if we see bruises, pressure marks, broken bones, abrasions, and burns, especially burns, if you're not a cigarette smoker and you're not a short order cook and you have multiple burns on your body, you're being abused, either by yourself, which that's twisted, knock it off, find another hobby, or you're being abused by your caretaker. Okay? People just don't get multiple burns. Okay? Unless, of course, they smoke cigarettes or they're a short order cook. Those are the only two patient populations that get burns like twice a month. Everyone else, that's kind of unusual for you to have multiple burn scars. Okay. Unexplained withdrawal from normal activities. People will just like withdraw into themselves if they're being abused. Especially the emotional and the verbal abuse, it just makes them uncomfortable saying anything because they're embarrassed about the situation. This person is like bullying them and they don't know what to do about it, but they know if they complain, maybe the bully will hear about it and then it'll just get worse. And so you'll see this person like withdraw into themselves, become a little bit more shy and introverted. And of course, you have to observe them over a certain period of time and see it like a transformation in their behavior. But that's a clear sign of abuse. And then, of course, sexual abuse manifests at the sexual organs. And so, rough treatment and injuries in that area of the body would definitely be a suspicion for sexual abuse. Sudden changes in financial situation. If you see that your neighbor was flourishing and doing well and was independent and now is suddenly struggling to buy groceries for themselves, um, it might be just skyrocketing inflation like we're all experiencing. But if it's not that, is there someone that has figured out a way to exploit them for financial gain? Do they have a caretaker that is cashing their Social Security check for them and or has access to the account and is skimming funds from it without telling the person? Okay, and so they might have unwillingly, you know how legal paperwork is, it's very confusing. And so it would be fairly easy for someone to sign away um, access rights to a checking account without even realizing what they're signing. And then the next thing you know, they don't have enough money in their accounts to take care of themselves. Bed sores, unattended medical needs, poor hygiene, loss of weight. That could be neglect. And again, it could be self-neglect. But if they have a caretaker, then the caretaker should be reminding them, hey, did you brush your teeth this morning? Have you taken a bath this week? Things like that. Set your bar high, people. One bath a week. um, Behaviors such as belittling, threats, or other uses of power and control, and you can tell when somebody's being manipulative. And so we need to watch for that with the people that come with the patient to the hospital. Are they pushing an agenda for ulterior purposes other than the best interests of our elderly patient? If so, that might be manifesting as a emotional abuse. Okay. And then anything that's strained or awkward and you can just feel tension in the room, pay attention to that. Really stop and slow down and listen to what's being said if there's any tension in the voice of either the caregiver or the elderly person. If they seem excessively nervous, or if they're squabbling, that might be a sign that things are not going as smoothly as they could be going. So not necessarily might not be an abusive situation, but a strained or tense conversation in the presence of some of the other signs it would be supportive evidence. Okay? Um, I'm sorry, I grew up in Yankee land, and families fight. That's just what they do. And we scream at each other. We rarely come to blows. Some of the more urban Yankees don't have any qualms about punching family members and getting into a real raucous melee. But yeah. We have, yeah, Yankees have different families, and lots of people have different families. So, um, yeah, so how much are they squabbling and fighting? Sometimes that's a subjective thing. Sometimes it's what you and your clan do is different than what me and my clan do, and yeah, that kind of thing. So you got to kind of watch and see, I guess. Term to use to describe the stereotyping of and discrimination against elderly persons, similar to racism and sexism, is ageism. Now, I would say that probably racism is a bigger issue than ageism or sexism, but that's because I'm not being discriminated against. So, um, when I get discriminated against as an elderly person, um, maybe I'll have a difference of opinion about that. But for right now, I think racism is a bigger issue in our society than ageism is. Attitudes of healthcare providers affect the quality of care. That's for sure. Okay. Um, you don't get to get tired of seeing patients. I don't care if it's the first hour of your shift, if it's the 10th hour of your shift, if it's the 16th hour of your shift. Um, I'm sick and tired of these patients. Yeah, you should find another job if you're sick and tired of these patients. Okay, that's what you're here for. All right, you are their servant. All right, if you're not comfortable with that role, maybe you belong somewhere else. It's just that simple. Okay. So if you have a lousy attitude toward the job, if you're jaded, if you're burnt out, if you're just over it, um, if you just don't bring a positive attitude, then you're bringing negative energy, and your elderly patient, none of your patients need it, but it might make or break the emotional well-being of your elderly person. It might be that you're the only one they get to talk to that day. And so be mindful of that. A lot of elderly people are lonely. We do get a spike at Christmas time of folks from the nursing home. And it's a lot of times it's the folks that don't have family members that visit them for the holidays. And so they fake a cough or a fever or make a complaint about this or that so they can spend the holidays in the hospital and they won't be alone. Yeah, that's where we are as a society. So just be mindful of that sometimes. Negative attitudes toward older patients do exist among healthcare professionals. Well, yeah, and see, it is so hard when you see, because I see this issue from both sides. I see the patient and what the patient expects, and then I also see the short staffing, and which is not the patient's fault. But I see the way healthcare is conducted and the number of burdens that are just handed down the chain of command to the frontline professionals. And they literally carry the mission of the hospitals on their backs. And it gets exhausting. Healthcare is exhausting work. And, if you've never worked in healthcare and this is your first time, you are going to have days that physically exhaust you. You're going to have days that emotionally exhaust you too. And I've seen that healthcare professional that, that has the negative attitude. I've occasionally had. Look, they scheduled me for 21 hours in a row. What was I supposed to do? I was starting to hallucinate. Of course, I was a little cranky. I didn't take it out on any of the patients, but I wasn't overly friendly either. And I'm sure that affected their care. I'm a human being and you're a human being, and we just need an awareness of this. Are you going to have a lapse? Are you going to get frustrated? Are you going to get emotionally beat down? Yeah, you're going to have a bad day like that. You are. Um, you got to remember lectures like these, and remember, yeah, Mr. Tillotson said there was going to be an awful day like this, but my next patient deserves my best. That's what he said. Yeah, see, I just said it on a recording. Your next patient deserves your best. It's as simple as that. Okay. All right. So, quality of elderly care, appreciation for the elderly, first of all. And so the culture has to change. And right now, we don't have an American culture that appreciates the elderly very well. Okay. We're getting better, but it's a slow process. Okay. Positive attitudes of providers. It is an effort. It is. It's an unrealistic, if you think about it. So most of the time when you're out in public as a healthcare professional, most for me it was, is you adopt a disciplined lifestyle when you become an X-ray tech, and you don't go out as much as you used to anymore because you have to be inside of 16 hours you're going to be responsible for patients again, and so you got to have a positive attitude, but that's not realistic. If you look at life, is it realistic that you're going to be happy 5 days out of 7? Is that realistic? And for you know, and for the hours that you're working, you're actually, earning a living, you're going to be happy for those. No, you're doing work. It's gonna be tough. You're gonna have to use your brain. You're gonna have to exert yourself. You're gonna have to exhaust some effort. Okay? You'll come to enjoy it, but it is going to be an effort at first, and it's going to be an adjustment. And maintaining a positive attitude is trying. Okay? Now, yeah, 5 days out of 7, that right there is unrealistic. Okay? In my experience as an adult, it's more like 1 or 2 days out of a 2 week period that positive attitudes and happiness comes around. That might be just me. I don't know, but um, it is something that you have to move to the front burner. You have to be a positive person. Um, you have to just keep pushing yourself to be a positive person because your patient deserves it. Okay? Sometimes the elderly are going in information and education regarding elderly and unique conditions. And so sometimes the patient is in a new, yeah, because when you get old, I mean, you hear jokes about it, but no one ever actually tells you what it's like. And yeah, there's all sorts of strange things that start happening to your body. You start growing moles. You start growing hair where hair shouldn't grow. Um, your joints feel kind of funny when it rains. Your eyesight starts to go. Um, your taste buds start to go. Now I still enjoy all the flavors, and I don't notice anything taste differently yet, but they say in this chapter that the taste buds do go. So, um, and so it's every part of this might be a new situation for the patient, but also it might be something that you've never seen before too. And so the best defense against ignorance is to eradicate ignorance. And ignorance doesn't mean you're stupid. It means you have an absence of knowledge, and you can fill that in with acquiring information. And so a little bit on your part, a little bit on the patient's part, um, gathering information and sharing information and communicating and learning about the patient and the patient learning about their condition, all of that just be having an awareness. It's like G.I. Joe said, knowing is half the battle. It really is. All right, so effects of aging. There's a picture of my knee. No, just kidding. It's not quite that bad. But this is advanced degenerative joint disease with spur formation and osteoarthritis around the knee joint. We've got several. We've got nearly a patellofemoral fusion going on out front. We've got several spurs on the femoral condyles and the tibial condyles. We got demineralization of the femoral condyle and the tibial plateau. The bone is just a little bit thinner. And then we got huge posterior spur formations with fragmentation, I think, in the posterior knee. And then looks like the fluid compartment is hypertrophied. So see the dark, there's like dark shadows in the muscle in front, above the kneecap and below the kneecap, and then above the condyles posteriorly. All those that's extra fluid accumulation around the knee. And so we've got some edema and some swelling too going on. But enough about the radiograph. Effects of aging manifest as physical changes, both bone structure in the case of osteoarthritis, which is fairly common, but also muscular structure. The muscles tend to atrophy, and they also tend to shrink, and so stretching is necessary to maintain ranges of motion. And range of motion starts to become hindered as the aging process continues. And so now cognitive changes, processing ideas, and keeping up with conversations. There starts to be a lag or a delay in understanding people as they're communicating to you. And so you will often have the elderly pause as you're taking a history and such. They will consider what you said, and you'll see the wheels the gears turning, so to speak. They're thinking about what you said, and then it'll be as many as 5-6 seconds, and then they'll start answering your question. Okay. Psychosocial, people become, the elderly become more aware of loneliness and the need for social networking than most folks. And it's because we let them retire. If we never let them retire, if they just kept working, then they wouldn't have social withdrawal. But it's because they don't see their coworkers anymore. They're kind of at home wondering what to do with themselves, and then they become socially withdrawn. Whereas if we would just keep them in the workforce through, all the way up to the end, then we wouldn't have this issue in our society. But of course, people get tired of working after a while, and they're not as productive as they were when they were 20, 30 years younger. So, and most jobs are about productivity. So, right. Most common complaints of elderly people: weight gain, fatigue, loss of bone mass, joint stiffness, and loneliness. Okay. So first four on the list, how do you tackle them? You exercise. If you have too much weight gain, exercise. If you are fatigued, exercise. That seems counterintuitive, but it actually does build your stamina up to exercise regularly. Loss of bone mass, well, if you're pushing weights, then your bones will actually start to grow stronger again, and you can actually limit the advance of osteoporosis by regularly exercising with weights. Joint stiffness, mobility, stretching exercises, um, physical activity like running or walking, things of that nature will help too. My joints are stiff when I roll out of bed every morning. Okay, but by the time I leave for work, they're nice and loosened up. And that's because I know that, yeah, everything's going to be a little bit tight and stiffened up when I first get out of bed. But if I just move through it, then eventually I can overcome it and um, my joints are acting as normal. Now, if I sit in a chair for too long, my knees do get a little stiff too. I've noticed that. So I'm thankful that I work at a job where I do get to walk around a little bit. Okay? Loneliness is probably the trickiest one to fix. The Western solution for that is nursing homes. Group them all together and let them watch Price is Right and play bingo together. And then they won't be lonely. Well, sometimes that works, but it's not ideal. They really don't want to make new friends. I mean, by and large, I don't know, maybe people do like to make new friends, but really the loneliness that's the huge deficit is friends and family don't have time for them anymore. Um, and if they're, especially if they're not independently mobile and can't get to the family gatherings as much as they used to, um, the loneliness and the social isolation really exacerbates when they can't drive a car or they can't walk anymore, or things of that nature. They feel trapped inside their house or in their residence or wherever it is they happen to be living. So, balance, coordination, strength, and reaction time all decrease with age. Okay, nobody wants to watch 80-year-olds play basketball. That's because balance, coordination, strength, and reaction time all decrease with age. Right. Cognitive effects, disease, aging, and disuse. Okay. And so that involves imbibing chemical substances to alter brain perceptions. Yeah, drugs and alcohol. Okay. Um, fears of cognitive loss. Everyone fears that. Everyone knows what it's like to be less than smart, or everyone knows how smart they are, and they're comfortable with that. They've grown accustomed to that. And it would terrify you to think that you're not going to be as smart tomorrow as you are today. All right, whatever your level of intelligence is, if you start losing some of that, then that would create a little bit of fear in you because, well, how much of it am I going to lose? Am I going to be able to dress myself and feed myself and still perform my, routine habits of daily living? How much cognitive loss are we talking about? And so, Alzheimer's disease and dementia are, um, they're not widespread, but they're common. Um, Alzheimer's is actually a subcategory of dementia. Dementia is the more broad category, describing a progressive loss or of congenital function that eventually deteriorates so that the person cannot perform daily tasks independently. And so dementia and Alzheimer's it's a rough diagnosis because you know that it's cumulative and it keeps progressing until it gets worse and worse and worse until the patient becomes an invalid. Um, yeah, that's a tricky one. It really is. Psychosocial effects. Does the person feel loved? Do they feel cared for? Do they feel like their life is still important and there's still a purpose for them to be around? Okay. this is not always the case. 1 in 5 persons older than age 65 are clinically depressed. Okay. So it's very, very common. It's a 20% chance. And I think that's probably an understatement. I think it's probably closer to 40% or 50%. Okay. Successful aging, greater social contact. Do they have kids and grandkids? Do they have regular contact with their kids and grandkids? Are they healthy, or do they have various syndromes or conditions that they're suffering from? Do they have a good positive outlook, and are they maintaining a quality of life that's still mostly independent? Okay. Low vulnerable personality traits. Are they naive or gullible? Basically, because that sets them up as an easy target for abuse. And then some of that is cognitive decline. And so if they're suffering from cognitive decline, they also will get depressed because they're likely going to be abused. Someone is going to try to take advantage of that situation. And that's the unfortunate truth. Okay. And then finally, stressful life events. Have they had personal loss or tragedy? One of the biggest things that affects the attitude of elderly people is, do they have a spouse, and is that spouse still alive? And when their life partner, their spouse, or whatever, that person they shared their life with is gone, it has a huge impact on, do I even have a purpose here anymore? So it's very, very tricky. All right. So factors that affect the risk of depression: are they ill? Have they had medical emergencies, or have they had a medical emergency? Are they on a fixed income, or are they financially independent? What are their choices for personal living arrangements? Are they still able to live independently? So as the aging process continues, it gets harder and harder to avoid, one, fixed income. Eventually, everyone gets to a fixed income lifestyle. And then two, choices in personal living arrangements. As your abilities to live independently decline, you kind of you're heading toward the nursing home or moving in with your children, one or the other. Whichever one will maintain the sanity of all the individuals involved the most is typically the way that things go. And if you listen to elderly people, they don't want to be a burden on their children. And they willingly go to nursing homes so that they don't have to be a burden on their children. And so that's part of the cultural norm too, is the elderly in this country think that they would be a burden if they moved in with their children, for their children to take care of them. So we need to be mindful of this entire picture and the entire spectrum of everything that it brings as we're dealing with the elderly population. They might not have a caregiver. They might not have a support network. They might be on a fixed income. They might be on government assistance. Lots of different factors influence their healthcare journey. Right, this is the slide that I dread. Oh, look, David Letterman. The slide that I dread because I can check off some of these boxes already. All right, so chronic conditions of our elderly population. Arthritis, yep, got that. Hypertension, not anymore, got it under control. I lost about 30 pounds over the last 2 years since COVID. So I gained 40 for COVID, but I've shed 30 of it back off. So and the hypertension went away when I lost weight. So hearing impairment, that's developing, so I'll give that like a half credit. Heart disease, no, not yet. Cataracts, no, not yet. Deformity or orthopedic impairment, no, not yet. Chronic sinusitis, that's another check. Okay, so that's 1, 2, and then a partial on the hearing impairment. Diabetes is a no for right now. Visual impairment is a yes, and that's also developing, like the hearing impairment. And then varicose veins, no, but it's a genetic trait. My grandfather and my father both had them, and so they're not manifest in me yet, but I am looking forward to their arrival. It's literally going to be any day now. So I won't be sharing. It won't be show and tell. You'll have to imagine my varicose veins. They've got an amazing laser surgery for that now that actually gets rid of those. So I might look into that. Of course, I'll have to wait for them to show up. They haven't showed up yet. So. Okay. All right, so organ systems that age: the skin, the nervous system, sensory system, part of the nervous system, musculoskeletal system, cardiovascular system, and the GI system. Okay. Immune system, respiratory disorders, hematologic, that is making blood cells, not just red, but white blood cells and platelets too. I'm not sure what that's supposed to be in the picture, but it looked kind of cellular, so I put it in there. Genital urinary system disorders, and then endocrine system disorders. Now, I told you this is the part that I cut content, so we won't get onto all of these systems. So I did go to the skin one because the skin actually becomes thinner and thinner, and we could actually tear the patient's skin if it's an elderly person and we mishandle them. Okay, so we got to be very, very delicate as we're handling people. Bruising, and as the skin becomes thinner and the membranes flatten and become more vulnerable, people bruise easier, and the skin can actually tear like tissue paper in extreme cases. And so also the skin becomes less of a guard against heat stroke when you are elderly. Okay. The fat pads on the feet start to thin out, and so foot conditions increase. Graying and thinning of hair. Exposure to sunlight is a major factor in the aging of the skin system, the intermedullary system. So I am fair-skinned and I play video games for a hobby. I've been playing video games since the Atari 2600, so to give you an idea how long it's been. Since I've been playing video games since the Atari 2600, especially as I became an adult, my recreational activities outside have become shorter and shorter and shorter, and I haven't exposed myself to as much sunlight as some of you folks have. But the other reason for that was an actual strategy by me. I understood that I was fair-skinned and that I'm more likely to suffer skin damage by being a redhead. My skin is more sensitive to malignant melanomas and basal cell carcinomas than other folks that are not fair-skinned. Okay? There's a pigment called melanin, and I lack that pigment. I have a deficit of that in my genetic makeup, and melanin actually absorbs UVB, and it can block UVB such that it doesn't mutate skin cells and damage skin cells. So the presence of melanin in your skin actually fights skin cancer. unfortunately for me, I don't have very much of that. So, nervous system disorders. Remember, I did say I thinned this a little bit. So, nervous system disorders. This is going to affect our patient because cognitive function effects and dementia and Alzheimer's and things of that nature. Cognitive decline effects are going to manifest as a hurdle to exam performance. And we're going to have to develop strategies for dealing with patients suffering from cognitive decline, whether it actually be dementia or if it just happens to be just the natural aging process and processing ideas goes a little bit slower, okay? Especially with new experiences. Okay? Other sensory system disorders, your eyes start going to crap. Around about middle age, mine are just starting that process. Of course, I've never been able to see long distances without corrective lenses. I can read just fine without any glasses at all. And I just got my eyes checked, and the doctor says, well, you don't need bifocals yet, but you're the right age range, so we'll test you again next year. It's like, thanks, doc. Thanks so much. Yes, my eyes are literally just turning into dust right before my eyes. And so, yeah, you see prescription lenses change, and then it gets bad, and then you see the Coke bottle glasses all over the place, and the prescription gets so wild that they don't even make a contact lens that strong anymore. So everyone's got to go to glasses, and you've got your reading glasses, and those are red, and then you've got your driving glasses, and those are black. And if you leave the house with your reading glasses on, you're going to get into a car wreck. It's just going to happen because you won't be able to see past the dashboard. So, and of course, you're going to need the bifocals if you keep driving, because to read the speedometer, you'll need the reading glasses, which will be the lower half lens. And then to see the road, you'll need the corrective lens to see far away objects, and that'll be the top half of the lens, and that's what a bifocal is. Reading glasses on the bottom of the lens, far away vision on the top of the lens. Hearing impairment is very common. Okay. Now I was a child of the 80s, and so Led Zeppelin, Van Halen, AC/DC, Motley Crue, Guns N' Roses, these were the bands of my teenage years. And so yes, I have done more hearing damage. I've probably got advanced hearing damage compared to other groups of people. It's just that was self-abuse. I did it to myself. I listened to my rock music loud, and now I have hearing loss, especially in a room with, you see it manifest in the classroom when there's multiple people speaking or there's a crowd of people, and I have trouble either figuring out what was said or where it came from, and you'll see me make that mistake over and over again in live lecture. Okay. Presbycusis is gradual progressive hearing loss or tone discrimination, more common in men. It's that you can't hear high pitches anymore, and you eventually lose the high pitch part of the spectrum. Okay, and I didn't think this was a real thing until someone showed me an internet video where there was high pitches being played, and I couldn't hear a thing. But then my son John, he was 16 at the time, he's like, "What is that awful sound you're playing on that video?" And we're like, "What? There's no sound." He's like, "No, it's definitely it's like a piercing tone." And it was basically like a dog whistle pitch, but Angela and I couldn't hear it. Only John could hear it because he had young ears. And so the higher pitched sounds, you have harder time hearing those as you get older. Decline in sensitivity to taste and smell. You know what? I'm one of those people that I don't eat to live, I live to eat. And so that might be what sends me into a depression is when I can't taste a nice ice cold beer anymore, or a steak, right? Or what is it? Good. Oh, homemade onion rings in beer batter, fried in beer batter. Oh my God. So if I'm going to have trouble tasting those things in the future, and I can't just savor those wonderful flavors, yeah, I'm not sure that life is going to be worth that anymore. So, yeah, decrease in saliva production and uh, dry mouth accompany loss of taste. Okay. Loss of smell, hyposmia is how that's pronounced, or hyposmia. Um, Accounts for decreased appetite. We don't realize that until we get a cold and we can't smell anything, how much the sense of smell adds to our understanding of the flavor of food. Okay? And it's because you encounter both of those things at the same time when you're healthy, but when you have a cold, everything tastes kind of off. It doesn't taste any different. It's usually you're smelling the food as you taste it, and both of those senses kind of overlap with each other. Okay. And so when you do lose your sense of smell, your appetite, and a lot of people experience this with COVID when they weren't able to taste anything or smell anything. They lost their appetite for food because the food didn't taste good anymore. My wife went through this. She lost a little bit of her taste buds and some of her smells. Okay, she kept smelling something burning, and we figured out that that was actually oh, what was that? Um, it wasn't it wasn't burning. It was actually a sweet smell that she was smelling, but she misidentified it as like the smell of charred toast, um, when it was actually a sweet smelling. It was like the smell of jelly or honey or some sugary syrup stuff. She was claiming that it smelled like burnt toast. So it was really weird. COVID did some strange things. So, okay, moving on to that was sensory disorders, vision, hearing, other disorders. Your musculoskeletal system. We don't see a lot of old men playing basketball and football. We don't see a lot of old ladies playing basketball and football, or any of the physical contact sports or things that involve dexterity and strength and a combination of both, and moving your body across the field in rhythm with either a bouncing ball or some such thing. It gets kind of complex after a while, and that's because your muscles and your joints don't move as good as they used to. Okay? Now, loss of bone mass, that's a serious consideration for women. Women are 4 times more likely to experience osteoporosis than men. And with osteoporosis, the thinning of the bones, we see an example here. This is a kyphosis with compression fracture. The vertebral body has actually collapsed upon itself and turned from basically a rectangle shape into a trapezoid shape. It's actually squished down on itself. Okay, and that's because the bony structure on the inside is basically disappeared. It's thinned out so much that it's hollow on the inside. It doesn't have any rigid structure holding it uh, holding it open anymore. Okay, and it just collapses on itself. Osteoarthritis is the second most common cause of disability in the United States. Okay, your symptoms are pain, swelling, decrease in range of motion of the joint. So osteoarthritis, that's something that I'm dealing with now. I'm in the early stages of it, but after about 5 minutes of, like if I'm laying down, like going to sleep at night, it takes me about 5 minutes to get everything moving again where it doesn't feel stiff and kind of painful. Okay. Getting up out of a chair, it takes me about 5 minutes before my knees feel right again. I know 10, 15 years down the road, that's going to be more like 20 minutes and popping a pain pill or two. And then 30 years down the road, it's going to be like, well, you know what? Getting out of the bed is overrated. And so I'm not going to get out of the bed. It hurts too much. Hopefully, I'll keep that decision off in the future as far as possible. Okay. Cardiovascular system. This system is critical to everything else. The way the rest of your body gets oxygen and sugar is the bloodstream. And so if you have a chronic condition like atherosclerosis or cardiovascular disease, and you lose the ability to circulate blood as well as you could be, well, it affects every other organ system. And postural hypertension, that's the orthostatic hypotension, becomes more common in old age than it is in young folks. I exhibited it once. I want to say it was class of 2016. I'm not sure of that. It was early on. I exhibited it once, right in front of a live lecture. It was like the week after I taught about it. It was like third week of October. So I just mentioned it the previous week. And all my students are pointing at me, because I stood up and I go, whoa. And I immediately grabbed the chair and put my butt in it. And they're all looking at me. And then one of them points and says, orthostatic hypotension. I'm like, yeah, I just got dizzy. So, yeah, it was a big learning moment. Let's hope I don't repeat the lesson for you guys. Um, so that was pre-COVID, and yeah, that was just kind of a random fluke thing. It happened. I stood up really rapidly, though. I do remember that. But I haven't had a spell like that since then. So, um, thank the Lord for that one. Arthrosclerosis. It's just you are eating too many fatty foods as part of the American diet. You're ingesting and producing way too much cholesterol, and the body has to put it somewhere. And so it starts lining the inside of your blood vessels with it. And so the cholesterol builds up into what we call plaque. And the plaque basically just is like putty or wallpaper paste on the inside of the vessel. And you put on a layer, and then you put on another layer, and then you put on another layer, and then before you know it, the the opening of the vessel, the lumen, starts to get narrower and narrower and narrower. And over time, a artery that, let's say it's got a normal diameter of about half a centimeter across, now it's only 2 millimeters across rather than 5 millimeters across because you've lined it with arterial plaque. You've lined it with cholesterol. Okay. Um, so this hardening of the arteries and a thickening of the arterial wall and the loss of elasticity, it can form aneurysms, it can form blood clots, it can create choke points, which create turbulence. And turbulence is one of the key factors that um, precipitates the blood clotting reaction. You ever wonder about that? Blood's a liquid till it's not. Yeah, one of the things is turbulence. So just extra turbulence, more than what it's accustomed to, the blood just knows to start triggering the chemical reaction to form a clot. It's really quite fascinating. Okay. Um, I don't know how blood manages to form a clot like when you get a cut. It's really weird. How does it know that it's not inside the vessel anymore and it needs to clot off? Isn't that strange? That's kind of that's kind of weird when you think about it. Okay. How does it know not to clot when it's flowing through your vessels? How come it doesn't just trigger a clot? Okay. Well, sometimes it does with arterial plaques. Um, so this will lead to possibly an embolism, like in the lung, a heart attack, or a stroke. If you're forming blood clots, those blood clots could break free from the plaque, and then eventually they occlude a blood vessel. Okay. Now, congestive heart failure, that's a different type of cardiovascular disorder. Um, but congestive heart failure is basically the heart grows too large and it can't efficiently pump blood anymore. Now, the way to prevent congestive heart failure is healthy diet, control high blood pressure, get regular exercise, and don't smoke. Okay. So let's see, control high blood pressure. Yep, doing that. Healthy diet for the most part, doing that. Exercise, I'll get back to you on that. And no, I do not smoke. Not at this time. When I'm 15 years away from my death anyway, the story may change. Okay. Not tobacco. Oh my God, that is so, no, no, not tobacco. The other one. That's what I'm talking about. Yes. Yeah. Yes, that one. It's going to be a fun retirement. You should stop by and visit sometime if you have a chance. Um, Immune system decline. So diabetes, pneumonia, nosocomial infections, all those risks increase with immune system decline. Infections, cancer, and autoimmune disease manifest more in elderly people as well, and they are all related to immune system decline. Cancer is regularly eradicated by your immune system in early stages. It's just as time goes on, the number of cancers that are possible keeps increasing in probability, and then eventually one of them gets the best of you. Immune system, elderly people are more likely to be infected by influenza, pneumonia, tuberculosis, meningitis, and urinary tract infections than everyone else. Okay? Part of it's immune system decline, part of it's because we decided to group them all together in nursing homes. And so some of that, like the influenza, the tuberculosis, the pneumonia, yeah, that's all social contact with other people who are infected with those things. That's typically how you get those things. Now, if you're an elderly person and you're around other elderly people, you're around other people who are infected with influenza, pneumonia, and tuberculosis. And so everything comes for full circle. Kindergarten is a great place for your kid to catch a cold that they can bring home to you. Well, the nursing home is a great place to catch pneumonia. So, respiratory systems disorders, your lungs lose elasticity, and so their ability to exchange oxygen and carbon dioxide with the same efficiency as when you were young is decreased. Okay, breathing muscles and the rib cage stiffen. That's the skeletal muscular changes. Unfortunately, we rely on the expansion and contraction of the rib cage for breathing, right? And so when the ribs become arthritic and stiff and the intercostal muscles atrophy because we're not exercising as much, it becomes more difficult to take in deep breaths and to properly oxygenate, and people get winded faster as a result of that. Uh, Increased frequency of emphysema, bronchitis, pneumonia, and lung cancer. Lung cancer is the most common cancer-related death in men and women. We still have the baby boomer generation. They didn't start banning the smoking of cigarettes until after I graduated high school. And so the early end of Generation X is where we're going to see lung cancer numbers. It will come in 2030, but the lung cancer numbers will plummet in our future. We just have to wait for all the smokers to pass away. There's still plenty of baby boomers that grew up smoking and can't break the habit. Smoking tobacco cigarettes is way, way down among people of all generations now. And so the prevalence of lung cancer is declining. And it will decline significantly once we get past the smoking ban age. So they banned smoking pretty much like late 80s, early 90s. That's when all the cigarette smoking bans came out. So the people who had grown up before then, they had grown up in a tobacco environment. They had grown up where friends or family used tobacco, or they used it themselves, and they already established a habit. And so the smoking ban didn't impact their health as much as it did when I graduated. So the people who were born in 1990 and later, like you guys, really benefit from the smoking ban because it's not all the time in your face. It's very rare to see people smoking cigarettes in public anymore. And so because it's not constantly in your face, you don't feel as much peer pressure, and you don't see it quite in the same numbers as you do in older generations. And that's because there wasn't as much strict regulations and basically outright bans on those activities until after I became an adult. But overall, tobacco smoking bans, I'm all for it. It should not be a daily activity. It should be a once in a while thing, if at all. And tobacco is definitely if it's a daily chronic thing that you ingest tobacco, smoke, or inhale tobacco, or use tobacco on a long-term basis with regular frequency, it definitely has a detrimental impact on your body. So, quick tips for the elderly. Take time to educate both the patient and their caregivers, their family, the sons and daughters. If the daughter is showing up, she wants to run the show. She wants to help make the decisions. She's taking that on as her role. Not all the time, but 9 times out of 10, yes. If the daughter is there, you should treat her like she's the one in charge. Okay? Speak lower and closer. When you're talking to an elderly person, get in close. Remember partial hearing loss. Now the men have an advantage because they speak with a more bass tone in their voice anyway. And that seems to be the tones that you can hear all the way through old age. And so speaking in a lower tone of voice is often helpful, and people can hear you better when you speak in a lower tone of voice. And so make your pitch lower, okay? More Jim Morrison, less Chris Cornell. Get out of my classroom if you don't know who those people are. Treat the patient with respect and dignity. Of course, you want to communicate with them warmly, show empathy, maintain a positive attitude. Remember, you are setting the mood for the exam. Okay? Set the mood, create comfort, understanding, involve them in the process, communicate, share with them, make them the partner in the exam performance, and the exam goes better. Okay? Provide rest time between projections and procedures. Literally, the 2-view chest x-ray. Patient came down on a wheelchair and it was like, can you stand? Yeah, for about 2 or 3. Yeah, I can stand for a couple seconds and then I'll need a rest. Okay, let's do this. I set up, I was like, how tall are you? I'm about 6 foot tall, so I set it up like it was like 4 inches low for me, right? And I set up, he's still sitting in the wheelchair. I set the vertical bucky height and I set the x-ray tube to where I think he's supposed to be, right? And I get everything lined up. I make sure the technique is set. I say, okay, stand up and grab hold. And then, okay, I got to adjust it. I was about a ½ inch off. And so I raised it up ½ inch. I'm like, here we go, taking a deep breath. And then I ran to the exposure switch. We exposed it. And then I ran back into the room and I sat him down. And he sat there for a good 2-3 minutes, catching his breath and getting his strength back. And so we just chit-chatted about him and what he was doing. I forget who his name was, but he was a nice guy. I remember chatting with him, and we just had a casual conversation while we were waiting for him to get his. He's like, I think I can stand again. I'm like, okay, we got one more to do, and I modeled it to him. I said, we're going to get a side view. You're going to be like this with your arms up. And I think we're at the right height, so we're ready to go. All I need you to do is stand up and turn so you're facing away from me. And he did. And he reached out and grabbed the bar, and I ran back. And he was standing for about 2 seconds each time with a 2-minute, 3-minute break in between. But we got a standing chest x-ray done. Okay. Let them use the handrails. Let them use the handholds. Let them use a standing support, okay, or some kind of bar or something they can grab onto for support. Now, adhesive tape, no, they've got thin skin that tears easily. Don't use adhesive tape to hold them in place. Sponges and sandbags, yes, all day. Okay, handrails, table pads, absolutely. Okay. Raise the handrails up if you can on the stretcher. That gives them, if you have to have them turn on their side or roll over or something, raise up the handrail and they have something to pull against. Okay. Blankets, sponges, and other positioning aids. You have to have them comfortable. These are going to be uncomfortable positions that you're putting them in. If you go out of your way to create some comfort for them, then they're more likely to tolerate the uncomfortable position. But if you make no accommodation for their comfort, they're going to subconsciously shift to a more comfortable position and get out of position. So make sure you accommodate for their comfort before you even start positioning. If you do leave them in one posture, this is more nursing side of the house than x-ray side of the house. But if we do leave them laying down in one posture for too long of a time, it does create a bed sore or a pressure sore. So we need to be mindful of that. Some of our bedridden patients will have pressure sores, and it might be uncomfortable for them to lay on the pressure sore. And so we'll have to make accommodation for that sometimes. Check the patient history before contrast administration with your elderly patients. Okay. Kidney failure or kidney disease could be possible. They might have difficulty swallowing. Okay. they're definitely at higher risk for aspiration, whether they've had a stroke or not. And so, if they have to drink anything like barium or anything else, better for them to sit upright and try to drink rather than reclining or laying down to try to drink. Okay. And so with contrast administration, just extra precautions. Okay. Joint Commission criteria, age-specific competencies, all healthcare professionals need to be evaluated annually to make sure that they are properly informed about geriatric care, including assessment and adaptation for visual or hearing loss or impairment, digestion and esophageal problems, grief counseling and grief concerns, and how to address and deal with a patient who seems depressed or anxious or is going through the stages of grief. And typically they have um, patient life. They call them various different roles: patient life coach and patient care representatives, and sometimes they just call it the social worker. And so there could be a county social worker or a municipality social worker, or it could be a social worker employed by the hospital to deal with um, some of the more emotional issues or some of the more um, grief related issues or depression related issues that you as an x-ray tech um, it might not be the depth of your wheelhouse. It might not be your exact skill set to understand the nuances of clinical depression as well as a social worker does, uh, or a patient care coordinator does. And so we can hand off some of these issues, but we do have to recognize when a patient is in a grief process or is in an emotional anxiety state or a fear state or some of that nature. And then we also have to recognize that at a minimum, patients like to be comfortable, warm, and safe. And so we have to be mindful of those needs as we're providing care to geriatric population. Okay. I had to be evaluated, and you will if you're employed in a Joint Commission accredited hospital institution. Um, you'll have to um, you'll have to be deemed competent in age-specific communication and assessments annually. Okay. And so it's for the elderly and for for the pediatric population. Radiographers need to know how to deal with some of the issues that we've talked about today in this PowerPoint. So, in particular, you need to know how to adapt your standard positions and procedures to accommodate for the different abilities of your elderly patient. You need to understand the physiological changes that are happening and how those can present additional risks like skin tears and easier bruising and things of that nature. You need to understand the pathology of aging and how that affects the way we communicate and share information with our patients. Okay, they might be hard of hearing. They might have trouble with their vision. They might be legally blind. They might be clinically blind, which is those are two. Legally blind means that you can see some things. Clinically blind means there's no visual input data at all. Okay. Um, Awareness of social, psychological, cognitive, and economic factors of aging. You'll have to understand that some people don't have the social safety net. They don't have a caregiver. They don't have um, family support. They don't have financial support. They just lost their spouse last year. All of these things could be happening to our geriatric patient. Okay. Now, just a quick, some of the more common things, and I'm not sure I included all of these. I might have included all these. So, accommodations that we do for common views, like a chest x-ray I've already mentioned, we're going to have them bear hug, and there's little hand grips on the side of the upright bucky. So we're just going to have, rather than have them put the backs of their hands on their hips and flex their elbows out, we're just going to have them bear hug the upright image receptor for support. Okay. We can also we can change the exam from a PA upright to a wheelchair AP chest if the patient's not able to stand. We just have to note that we've made that change to the radiologist. Okay. Always, if you make a change, the default is, the expectation is we're doing a PA and lateral if it's a 2-view chest. If we deviate from PA to an AP, we should be writing a note either on the radiograph as a digital commentary or in the patient's chart or exam comments or wherever it goes. We need to write that we did in fact shoot an AP instead of a PA. Okay. Spine, for the laterals, you're going to have to prop them up. Elderly people do not like laying on their side, especially on a hard table. It's not very comfortable. They feel like their hip bone is grinding into the table. It's uncomfortable. It hurts. And they will try to shift position and then get into an oblique rather than a true lateral. And so we have to use some sponges and maybe some extra padding, maybe a pillow between their knees if we have a pillow. Sometimes upright radiographs are more comfortable than laying down radiographs. Seated positions might be used instead of a true standing upright position. Okay. Pelvis and hip fractures are very common in elderly folks, especially status post fall. So if the reason for the exam is S/P fall, that's status post fall, then you treat the hip like it's fractured until you've convinced yourself by radiographic evidence that it is not fractured. And so the rule of a fractured hip is don't move a fractured hip. The femoral artery is only, in some cases, half an inch anterior to the fractured hip. And so don't move a fractured hip because a jagged piece of bone could lance that artery and then they have an internal bleed. And if your femoral artery is severed, you can bleed out in as fast as 2 minutes. And so we absolutely do not manipulate a suspected fractured hip. You're going to switch the way you do things from the conventional hip views to a cross-table lateral view. Okay? Without rotating the body. You don't manipulate suspected fractures of the hip or the shoulder. Technically, you don't manipulate any fracture. It's better practice to not manipulate anything. For the upper extremity, limited flexibility and motility, especially in the shoulder. Stroke might cause contracture of limbs. If the limb is contracted and it doesn't extend and straighten out, you shouldn't be forcing the limb into an extension. Okay, you can do serious injury to a person. And then also sponges and sandbags to help with positioning, and use a cross-table projection when you have to. Okay. For the lower extremity, um, there's also limited range of motion and flexibility. In particular, the ability to frog the hip for lateral projection, whether it's fractured or not. Old people cannot do that. They cannot frog their hip. And so what we typically do is we end up obliquing the pelvis in combination with an attempt at frogging the hip, and then we get a reasonable lateral hip radiograph. And I'll show you how that's done when we get to the hip x-ray. Feet and ankle exams, you don't have to move the patient out of the wheelchair. They don't do a transfer that you don't have to. And so you can do hand, wrist, forearm, and elbow x-rays, but also foot and ankle x-rays with the patient in the wheelchair, and you don't have to move them out of the wheelchair. You should be able to figure out a way to pull off all those x-rays while the patient is sitting in a wheelchair. Okay? So again, if you don't need to transfer, what's the chance that a patient falls during a transfer that doesn't happen? And the answer is 0%. And so if you're not doing the transfer, that's one less chance for the patient to fall. Okay? Don't do it. And that's one less chance for you to throw your back out too. So again, don't do any unnecessary transfers. If you can do the x-ray with them sitting in the wheelchair, then do the x-ray with them sitting in the wheelchair. Technologists should keep the patient in the wheelchair or stretcher to perform extremity examinations. You do not have, just because you brought them to the exam room doesn't mean you have to move them to the exam table. You can do the same projections on a stretcher that you can do, or in a wheelchair that you can do on the table, for the most part. Okay. Now, like a KUB, no, they've got to move over to the table. Okay. Lumbar spine, yeah, they're going to move over to the table. But most of your extremity work, you can do it right in the stretcher or right in the wheelchair. Techniques will have to be adjusted for the elderly. Typically, we're seeing more of the asthenic and hyposthenic body habituses, so we're reducing technique for that. Tissues degenerate and usually get thinner with the aging process, and so we'll be lowering our technique for that as well. Okay, an osteoporotic spine does not require as much mass and kVp as a 20-year-old person's spine. Okay, and that's because osteoporosis is a destructive pathology that it's actually what's absorbing the x-ray is the calcium phosphorus lattice. Well, osteoporosis is a thinning out of that lattice. So there's literally less calcium atoms to absorb the x-ray. And so the bone tissue becomes more and more radiolucent as the disease progresses. Exposure time is critical. Shorter exposure time, just same strategy as we use with the kids. For the children, we want short exposure times, and the reason is they throw temper tantrums. For the geriatric population, it's because they've got the tremors or the shakes. They have involuntary motions. Okay, if you have a patient that has tremors and they can't hold still, just drop your exposure time out and you'll get rid of the shaking motion. Okay. Elderly people might find it difficult to maintain standard positions. Support sponges, the angle sponges, like an oblique hand. Anyone under 50 years old, yes, you can hold your hand at a 45-degree angle to like a solid table surface underneath it without much trouble. But if you're 80 years old, that becomes very, very tricky to do and hold it still. Okay, it's just a different ability at that point. Okay, breathing instructions. People will mess up breathing instructions. So we've got cognitive decline and decreased lung function. Okay, and so these are people that haven't taken a deep breath in almost 20 years. in some cases. And so you can say take a deep breath, but they've been just doing relaxation breathing, right? Not even thinking about their breathing, and they're not really, unless they're exercising regularly, they're not straining the limits of their respiratory system, and taking a deep breath is going to feel kind of awkward. There's going to be kind of a lag to compliance with the instructions. That, and they're not used to people telling them to take in a breath and hold it. And so they got to think about what it is you just asked them to do. It's, oh, he said taking a deep breath and hold it. Okay, I guess I need to do that. You mean now? I've literally had an elderly person say that to when I said taking a deep breath and hold it. And then I looked and they're like, you mean right now? It's like, yeah, right now, yeah, go ahead. So, and I've also had other techs, um, like taking a deep breath and hold it. And then they didn't look and then they exposed. And then the patient said, what did you say? And so just be mindful of that with your geriatric. Remember, hard of hearing. Okay. Hey, look, we got to the end. Sorry. Oh my God, an hour and 40 minutes. You poor, poor people. I am so sorry. Um, well, hopefully, you didn't lose much sleep over this. Um, Bottom line is you got to understand elderly people are falling apart and they can't do things as good as young people can do. And it's going to take a little bit of time and a little bit of patience, and they're always cold. So bring them a blanket before you do anything. All right, guys, I'll see you in class tomorrow. Take care.